Hello and a very warm welcome to this digital conversation on digital remedies for healthcare and the new normal, co-hosted by the UK-ASEAN Business Council and the ASEAN Business Advisory Council in partnership with AstraZeneca. To lead today's discussion, we have Baroness Neva Rolfe, Chair of the UK-ASEAN Business Advisory Council, and we are honoured to have Dr. Khuong, the Chair of the ASEAN Business Advisory Council in Hanoi, to give some welcome remarks, along with a fantastic lineup of speakers from London, UK, ASEAN and global Kuala Lumpur and Shanghai from UK, ASEAN and global organizations. We are also delighted to have the Vice Minister of Health of Vietnam join us today, Dr. Doan. Along with the panel address, we were also delighted to have Professor Richard Hobbs, Head of Department of the Nuffield Department of Primary Care, Health Sciences, University of Oxford. Associate Professor Dr. Khuong, Director, Division of Programs for Disease Control at the WHO, the World Health Organization. Dr. Faisal Idzwan Mustafa, Consultant Public Health Physician and Deputy Director, Non-Communicable Disease Section, Ministry of Health, Malaysia. Dr. Harpreet Sood, Board Member of Digital Health London, and Ms. Jo Feng, Senior Vice President for Asia Area, AstraZeneca. I'm Alan Lai with the UK-ASEAN Business Council based in Brunei and have a couple of notes to highlight before we begin. Firstly, we'd love to hear your thoughts and questions and invite you to post your comments in the question box at the bottom of the screen and our chair will pass them on to the panel. And secondly, if you are on Twitter, do tag us at UK-ASEAN and ASEAN_BAC and use the hashtag UK-ASEAN. And now to lead us through this very important discussion on digital remedies for healthcare and the new normal, I'll hand over the session to our chair. Baroness Neva Rolfe has had 3 careers in politics, in business and in the civil service. A former UK business minister and board director for Tesco, Baroness Neva Rolfe is now an active peer in the House of Lords and has tremendous experience and passion for Southeast Asia. Baroness Neva Rolfe, over to you in London.
Alan, thank you so much and thank you for the introduction. It's a great pleasure to be with friends and new contacts on this digital seminar. As Alan says, I love ASEAN, I love Vietnam, so it's great to see you, Deputy Minister, having worked there and also visited as a minister. A welcome to everybody and a very special welcome to Dr. Khuong and the ASEAN Business Advisory Council, who are hosting this with ourselves and our partner AstraZeneca for today. And we chose the theme because we want to get an understanding of the challenges the healthcare system in ASEAN is facing right across the ASEAN and identify solutions, including digital solutions, to help NCD care. So I hope that in the next hour and a half, we'll get a really good idea of what the future for healthcare looks like and some of the emerging trends and opportunities. But first, can I hand over to Dr. Khuong, who of course is based here in Hanoi and is chairman of the ASEAN Business Advisory Council, a council with which we have a very good partnership. And it's a role he's playing, as I know, for the second time. He first did that in 2010, so he brings enormous knowledge and has had a lot to do with the very successful development of ASEAN. He's vice chairman of the Vietnam Chamber of Commerce and Industry, which represents the business community in Vietnam and also promotes international trade very vigorously. Over to you, Dr. Khuong.
Thank you very much. Good afternoon. Dear Madam Baroness Neva Rolfe, Chair of UK-ABC, Your Excellency Professor Dr. Nguyen, Deputy Minister of Health of Vietnam, distinguished guests, ladies and gentlemen. First, let me express my warmest welcome to all participants for taking time to attend this meeting. I wish you all and your families stay well. I would like to express my thanks and appreciation to Madam Baroness Neva Rolfe and UK-ASEAN Business Council for organizing this digital conversation to discuss on digital remedies for healthcare is new normal. As you all know, especially in our topic of discussion today, non-communicable diseases, NCDs, are a burden for most emerging markets and developing countries, including Vietnam. The government of Vietnam has adopted the National Non-Communicable Disease (NCD) prevention and management strategy, which includes a target to reduce the premature death rate due to NCDs by 20% in 2025 compared to that in 2015. But we do hope that digital technology will revolutionize healthcare delivery and should be the most powerful enabler that low and middle income communities can use to address the growing burden of non-communicable diseases and NCDs, ensuring that all people can access the needed health services without suffering financial hardship. In the case of Vietnam, we can say digital technology is transforming healthcare in Vietnam. Major socio-economic and demographic trends are driving changes in healthcare demand in Vietnam. While public hospitals face challenge of rising demand for healthcare services, private hospitals face expectation of higher quality of care and service, as well as increasing competition. Digital technologies therefore comes as a promising measure to enhance efficiency and promote cost control without compromising on patient care. Healthcare digitalization in Vietnam has significant room to grow given early stage of development. Amid the ongoing pandemic COVID-19 cases, digital channels are also being used by the government to provide information, raise awareness, and educate people in containing the spread of the virus. Private hospitals in Vietnam are making a digital push to enhance their value proposition, also training on IT application for pharmaceutical and other healthcare professionals, and also provided by Ministry of Health to strengthen their prevention and control capability amid the ongoing cases of COVID-19. And I do believe that Deputy Minister Professor Nguyen will talk to you about that in details in today's meeting. As for medical device companies, they leverage digital technologies to improve patient outcomes, such as digital radiography, PACS, risk, remote technical support, and AI solutions. Vietnam is one of the fastest growing medical device markets in Southeast Asia, with an estimated growth of 9.6% annually between 2017 and 2020. Meanwhile, Vietnam health tech startup has room for even further growth, as it still attracts less than 2% of total investment in Vietnam, recorded at $7 million in 2019. In conclusion, I'm happy to participate in this meeting to learn more of how digital transformation of healthcare will make it more accessible, affordable, reliable, and inclusive. I believe that this kind of event will help businesses a lot to learn the best practices, knowledge, and know-how. Once again, I would like to reaffirm that ASEAN in general and Vietnam in particular welcome cooperation with UK-ASEAN Business Council in order to provide businesses with practical assistance and support to help them to survive this pandemic and facilitating our mutual cooperation to the new level. And I would like to take this opportunity to inform all of the participants of that ASEAN Business and Investment Summit, the biggest business event in the region in ASEAN, which will be organized back-to-back with the 37th ASEAN Summit in this coming November 2020 in Vietnam. And also for the information, ASEAN also will going to have dialogue with the Secretary General of ASEAN, Mr. Lam Chok Hoi, in the day after tomorrow. We talk about our recommendation to help ASEAN to survive in the pandemic. And one of the topics we dialogue with His Excellency Secretary of ASEAN is that we talk about digital remedies, also healthcare, and so on and so forth, the day after tomorrow. And also the main theme of our ASEAN Business and Investment Summit will be Digital ASEAN, Sustainable and Inclusive. And the event also we will talk about the digital technology. And we expect to welcome all you in the coming event in the coming November in Vietnam, if possible. So thank you again, and wish you all every success. Thank you very much. I wish the event a success. Thank you.
Dr. Khuong, thank you so much. And I'm very much looking forward to seeing you in Hanoi in November during the ASEAN Business and Investment Summit. I look forward to participating in. Please also give my regards to the Director General of ASEAN. He has a very, very important job. And we've had dealings with him, sadly, remotely in recent months. But it's now my great pleasure to introduce Professor Dr. Nguyen Truong Song, Deputy Minister of Health for Vietnam. Vietnam has been one of the most successful ASEAN countries in dealing with the coronavirus, as we've often noted on these calls. He recently spearheaded the response to the second wave in Da Nang, and we're particularly interested to hear how Vietnam dealt with that. But of course, the professor's research focus has been on cancer in the past, and he is well placed to address the challenge of non-communicable disease in the COVID-19 environment. So, Deputy Minister, over to you for your keynote address, with many thanks.
So, first of all, I will thank you for Mrs. Baroness, Chairwoman of the UK-ABC. Ladies and gentlemen, firstly, on behalf of the Vietnam MOS leader, we would like to thank you to take me to have an honor to participate for this meeting. And the subject of this meeting is a digital remedy for healthcare in the new norm, strengthening for NCD care. Firstly, we would like to say something about the NCD. Firstly, non-communicable disease are increasing globally, and NCD deaths account 71 of all global deaths, especially over 85% for premature deaths are in low and middle income countries. Given worsened situation of COVID-19 all over the world, scientific evidence and practice in Vietnam show that the elderly NCD patients such as cardiovascular disease, diabetes, COPD, cancer, and end-stage renal disease are more severely impacted by COVID-19. The health system suffer heavy impact by double burden for both communicable and non-communicable disease. The implementation of strategy and inaction in response to COVID-19 pandemic is reality has minimized the non-emergency care and treatment activity at healthcare facility, especially for the chronic disease or non-communicable disease. In Vietnam, during pandemic time, the NCD management and treatment service have been affected. For example, the health service provision was disrupted partially and totally. Healthcare staff was rearranged. NCD health workers were partially or totally reassigned to support COVID-19 fight. Our technical staff were isolated. The planned technical service was postponed. Public screening program such as the screening of the breast cancer, the cervical cancer, public was postponed. To prevent and control COVID-19 and to maintain the provision of NCD management and treatment services, Vietnam have conducted some response activities, include the non-digital and also digital solution. For example, we developed a national guidance of NCD management and treatment during COVID-19 context, which include for the guidance on treatment management and provision of the medicine for NCD patients from 1 up to 3 months instead of the maximum 1 month. as per the regular drug provision regulation. Develop the recommendation for the elderly and NCD patient on COVID-19 prevention and control and patient self-management. Implementing for the project of telemedicine. Guiding on the payment of medical examination and treatment covered by health insurance for NCD patients. Direct the strict implementation of NCD management at community health center and directing the central and provincial facility to only receive the serious cases that lower level could not handle. And request the patient to contact and register prior examination and treatment of regular disease, providing on-site examination and treatment services for patients in isolation area, conducting communication and online counseling for NCD patients, and deploying digital health applications such as for individual health record, etc. In today's forum, digital remedy for healthcare in the new norm, strengthening NCD care, the experience exchange and sharing by experts and in international partner, and the practices in Vietnam shall help Vietnam Ministry of Health develop and implement feasible solutions to assure effect of COVID-19 prevention and control and continuous and effective management of NCD in the new normal at the same time. On behalf of the leader of Vietnam Ministry of Health, I would like to thank distinguished leader, expert, and participant for attending for this forum. I hope that via the discussion between the participants in this meeting, we have the opportunity to understand more deeply and also sharing for our experience in the how to manage NCD during the COVID-19 pandemic. And once again, thank you. And I hope that we will satisfy for all of the questions if I can.
Deputy Minister, thank you very much indeed. That was very interesting, and certainly there was a parallel with experience here in the UK, where we've seen a very serious erosion in treatment for cancer, heart disease, and so on. That has, been squeezed out by the need to treat COVID patients. I wanted to ask you a question, if I could. About the implications of the digital technology that you touched on as being used during the COVID crisis. Are there sectors in Vietnamese society who find it difficult to use technology? For example, the older generation or others who perhaps don't have access to Wi-Fi. Is there a digital problem in Vietnam?
This is a very interesting question, and I think that the situation in Vietnam and also in UK and in the other country, especially for the low and middle income country, this is a big challenges. In Vietnam, when we have a policy from the government to digitalization for the government, so that the healthcare system led by MOS is one of the first ministry try to implement for digital health in Vietnam. And I think that the COVID-19 is a challenge, but also an opportunity for us to extend and implement fastly for digital healthcare. We got many difficulty because the mobile and the Wi-Fi and the population in the highland and the forest area they are still poor, so that the equipment, the digital tool and also for equipment for them is a big challenge for us. But now we also have a project that the contact point from the people to the healthcare system in the grassroots level, so that if not, the patient can come to the grassroots level. And we have the doctor, we have the nurses at Nguyen Health Center, and they receive them, and they use the digital equipment contact with the upper level hospital, and they get the advice, the consult from the upper level hospital to the grassroots level, and the patient no need to go far, no need to come back to the other hospital. So I think that is one of the good solution for us.
That sounds a very good approach. That helps with the elderly as well as people who don't have internet then.
Yes, in COVID-19 pandemic in Vietnam, we advise for the elderly and also the NCD patients stay at home.
Oh, right.
Stay at home, and the health worker will come to their house, and they will check and the health worker will bring for the mobile phone, and they can contact by Zalo, by Viper, yes, to the grassroots level and community health center, and that is the way to contact with them.
Very interesting. A sort of linked issue that has been debated a lot here is about mental health problems. Have you seen mental health problems increasing as a result of the pandemic?
That's true. And we are very regret that up to now, for the mental health, we got many cases in the COVID-19, especially in the quarantine, in the when they stay home, when they isolate, and when they isolate. For the mental health caring is a big problem. But in Vietnam, up to now, is the human resource for the mental health is still lack. So I think that is a big problem for us, and I hope to understand the situation such as in UK, and how about you can solve for this situation.
Well, Deputy Minister, I think we'd be very interested in having a further conversation about that, perhaps with some of our members who really understand these issues, and the professors who we'll be hearing from. I'd like to thank you very much indeed for your keynote address. Extremely interesting and very relevant, and I hope you'll be able to stay for some of the panel, which I am now going to introduce. In fact, I think in the interest of time, I will introduce each panel member as they come onto the stage, as it were, the virtual stage. And I have particular pleasure in introducing Professor Richard Hobbs, who is Head of Department at the Nuffield Department of Primary Care Health Sciences at the University of Oxford. Oxford University has been leading on the clinical trials for the vaccine, as I think everybody knows. And of course, a vaccine is the game changer, and the timing of its availability impacts on when the world can return to normal, a situation we're all very much longing for. Professor Hobbs's area of expertise is in primary care. He has led the University of Oxford to be one of the largest and most highly ranked centres for academic primary care globally. Professor Hobbs, we're much looking forward to your presentation. I think your slides have been loaded. Perhaps you'd like to give us a forward look, you know, COVID-19, where we are, and has it changed NCD care forever? Thank you.
Thank you, Baroness. Yeah, I've been asked to just set the scene and make a few observations, and I'm sure we'll touch on these in the discussion. I could have them. Next slide, please. So in the next 10 minutes, I'm really going to briefly summarize why long-term conditions are still incredibly important in terms of healthcare, and just briefly mention some of the ways that digital science can help us get back on track. So these data are from the Global Burden of Disease, the WHO study that basically transformed the way WHO think about what the most important health priorities in the planet are. Because when this was first published in 2012, it basically relegated, you might be surprised to hear this now, but relegated acute infective illness and malnutrition to less important causes of death and morbidity. And it's the classic long-term conditions, particularly ischemic heart disease and stroke, as you can see in blue on the slide, that are responsible not only for more deaths, but also for most disability on the planet. And therefore the risk factors for these diseases, namely high blood pressure, smoking, elevated lipids, are the most important preventable risk factors on the planet. Next slide. Next slide, please. And what's also important to note is that this is true in all countries on the planet, because the changing demographic with an increasingly elderly population in most countries on the planet, meaning that these truths about disease and risk factors are prevalent everywhere. Next slide. What's also become apparent is that it's not just single diseases that societies and health systems are facing, it's a combination of diseases, multimorbidity. And by the age of 50, these are Scottish data, but they'd be replicated in most countries. By the age of 50, on average, 50% of the population will have at least one long-term disorder, and by 70, 50% of the population will have at least 3 disorders, increasing as we age. Next slide. So if you look at a condition, important conditions such as diabetes, then only under 20% of patients actually only have diabetes. And for those under 65 with diabetes, they on average will have 3 additional conditions, and those over 65, 6.5 additional conditions. So long-term conditions are an absolute priority for health systems. Next slide, please. So are they still important, though, in this time of COVID? And I think they are. They remain, actually, despite our focus on deaths related to COVID. Long-term conditions are still the most important causes of death on the planet. And indeed, even in relation to COVID, as we know, although hospital and mortality risk is linked to some population demographics such as age and ethnicity, the most important risk factors are existing medical problems, and especially long-term conditions. Another important factor in relation to COVID is that, as we've already heard from the Deputy Minister, health systems have reduced access to chronic follow-up of patients and indeed acute diagnostics. And that reduced access has also been coupled with patient fears over attendance. So in the United Kingdom, for example, rates of referral with conditions that would have resulted in a rapid 2-week appointment at hospital because of possible cancer symptoms, they dropped 80% during COVID. So it's not just lack of access in the system, it's also reduced uptake of care from patients. So are there digital remedies? And what I'm going to briefly do is talk about 3 areas that I think digital health can help. I'm also going to end, because I was asked to, on vaccines, but I should also remind ourselves that reducing risks of COVID infection in terms of social distancing, masks, test and tracing are very important public health measures still, although I think that focused digital solutions can help us get back some of the ground that we've lost. Next slide, please. So let's just look at those three possible areas. There are lots of other areas. I'm sure we'll expand on those in a minute, but one reason for focusing on them is that we've established an Institute for Applied Digital Health here in Oxford, and amongst the 6 big research themes we have, each of these 3 areas I'm talking about have been focuses in the department. So the first is, rather than use crude estimates, everybody who's got hypertension or everybody who has asthma as a risk factor for COVID and potentially end up requiring patients to be shielded, can we produce more predictive measures that would enable us to be more focused in individuals that have most to lose by being infected with COVID and therefore should be most protected? And so we are producing a COVID risk calculator score, and I've used as an example here the Q-risk score developed by a team here now in Oxford, which is used to determine patients at accelerated risk of cardiovascular disease and whether they should get more intensive treatments. And that group are now focusing on producing a rapid predictive calculator for COVID worse outcomes. Next slide, please. Another important area is to determine the gap in practice, i.e. how far behind are practices that have the population at health at mind, how far behind are they in the preventive activities that would form follow-up for chronic disease. And again, one example of this, we actually run the national flu and acute respiratory infection, including COVID, national surveillance in the United Kingdom through the Oxford RCGP Research and Surveillance Centre. And what we have been piloting in this centre is regular feedback to practices, currently weekly. It will move to daily feedback, which tells them how far behind they are in the target populations for whatever condition we're providing feedback for. In this instance, I've shown examples of influenza and pneumococcal vaccines, of which patients would be eligible, which have received the vaccine, and therefore what proportion of the population are still to receive a preventive activity, and benchmarks that to the total central network of practices and national statistics. Next slide, please. And another big area that we're investing in is more patient self-management. And again, digital solutions are key here, whether through diagnostic devices, wearables, etc. And this is one example we've looked at in relation to hypertension. Hypertension is the most important long-term condition on the planet. It affects about 12% of population in many countries, so it's extremely common and obviously is an important driver of cardiovascular risk, as we saw earlier on. What we've done is develop algorithms digital algorithms that assist patients in determining their own management, i.e. will give guidance to them about how they adjust treatment based on their own self-measurements using validated devices. And this clinical trial, which compared standard care, going and taking your own blood pressure and going to your GP to get treatment changes, compared that to one where the patient did entirely self-management and showed that they had an improvement in their blood pressure control of 4 millimeters of mercury systolic at 6 months, which actually not only remained but improved at 12 months to 5.4 millimeters of mercury. Now you might think that's a small reduction in blood pressure, but next slide. Epidemiology would suggest that in fact a 5 millimeter mercury reduction in blood pressure will have a 10% reduction in CHD mortality and a 14% reduction in stroke mortality. And obviously we're following up these cohorts to see whether what we would expect in epidemiology is borne out. So before I close, next slide, please. I was asked to put just a few slides in relation to the Oxford vaccine, and I'll close with just 3 slides in relation to that. The technology is a well-established one. It's looking at chimp adenovirus. Why chimpanzee adenovirus? Because we have no immunity, obviously, to adenoviruses in chimps, but it has been inactivated, so it can't actually produce infection in humans. And they engineer it to stick the COVID spike on it, so that antibodies developed to this engineered adenovirus will actually be hopefully active against COVID. Next slide. The team in Oxford who had developed this, it's been an extraordinary race. It was incredibly quick that China actually produced the genetic sequence for COVID in mid-January, and within 104 days, the scientists in Oxford had actually produced the vaccine that was being tested for the first time in humans. Next slide, please. If we look at the phase 2 data, this basically demonstrated not just safety in the phase 2 population, but it showed a good immune response. So on the right there, you can see convalescent serum, and in the blue dots, it's the antibodies generated by patients who had severe disease. And in the middle 2 boxes, you can see the immune response in people receiving the Oxford vaccine, either a single or in the box to its right, a double vaccine. So you're getting a similar IgG response from the vaccine as you get if you've been infected with COVID. And if you look at the far left, compared to the control vaccine, which is a meningococcal vaccine, which produced no IgG COVID antibodies. Next slide. And there's also a very good T cell response as well. That's important because that's more long-term immunity. And again, left is control, middle is the COVID vaccine, both single and double shot. So that's a rapid canter through why this is a very important topic and how some digital solutions can contribute to this awful pandemic. Thank you very much.
Richard, thank you. Admirably clear and speedy, and it's very nice to see these further pictures of Oxford looking quite beautiful. So thank you. We look forward to your taking questions on the panel. We now move on, and I'd like to introduce Dr. Tran Jiang Khuong, who's Director of the Division of the Program for Disease Control for the Western Pacific region of the World Health Organization. She is the first Vietnamese woman appointed as a director for this sort of work, and she's in charge of the COVID-19 response in the Western Pacific region, covering 37 countries, and so that's a population of 1.9 billion people, so an enormous responsibility. And Dr. Tran has over 25 years experience working in the Vietnam Ministry of Health. Delighted to be so well represented today, and it's very well placed to help us to understand the challenges that the region is facing and that the solutions that the WHO is looking at. Dr. Tran, I think you're sitting in Manila, and I'd like you to talk to us about the main challenges for NCD care in Southeast Asia that you are now leading.
Thank you very much, Madam Baroness Nuffield, and Chair of the UK-ASEAN Business Council, distinguished guests, ladies and gentlemen. It is my great pleasure to be part of the panel to discuss on the urgencies of the situation to maintain the essential health service for NCD during the unprecedented time of the COVID-19 pandemic. Next slide, please. As you may know, and Madam Chair already mentioned, the Western Pacific regions is comprised of 37 countries and territories with a population of 1.9 billion people. and in which 7 ASEAN countries belong to this region. And during the COVID-19, the region experienced was the first, the already reported case from China, and up to now, the total number of COVID-19 confirmed cases in the Western Pacific region is 580,000 cases, with more than 12,000 deaths. And as compared with other regions in the world, the Western Pacific region reported the lowest number of confirmed cases, as well as the lowest number of deaths in the world. And however, the impact of COVID-19 to essential health service, including NCD service, are still very huge. Next slide, please. Before COVID-19 pandemic, the NCD burden is already huge in the Western Pacific region. According to the statistic in 2016, 82.5% of all premature deaths due to COVID-19 was in the Western Pacific region. And as the Professor Richard Hobbs already mentioned, that our, the region as other part of the world also experienced the shift from infectious disease to NCDs and aging. We in WHO, we have done a quick survey on to conduct the quick survey on the impact of the COVID-19 to NCD service. And it is reported that the Western Pacific region have experienced 12 countries out of 27 countries reported the partial disruption in outpatient NCD service. And also, we also observed 4 countries reported that the inpatient service for NCD was limited to only emergency care. And around a third of countries reported partial disruption in the management of hypertension, diabetes, cancer, and cardiovascular emergency. Rehabilitation and palliative care service also partially disrupted in 11 countries and 7 countries respectively. The outpatient service for cancer treatments also disrupted in a number of countries. And in the keynote speech of Professor Nguyen, the situation in Vietnam also clearly illustrated this trend of the impact of COVID-19 to NCD services. The cost of these services, it was due to the demand side and the supply side. For the supply side, it was include the closure of outpatient and inpatient care, as we have just described, and the closure of population level screening programs, and the deployment of NCD staff for COVID-19 response, and the unavailability of essential medicine and health products at some healthcare facility, including PPE for healthcare workers. From the demand side, there was a drop in outpatient numbers and cancellation of inpatient elective care due to the fear of COVID-19. So in 2019, the member states in the Western Pacific region put out for the shared vision to make the region is the healthiest and the safest region in the world. And with the leadership of our regional director, Dr. Takeshi Kashai, and with the collaboration with member states, we have developed for the future vision document that we focus on the 4 thematic priorities. The first one is health security, including AMR. The second priority is NCD and aging. And the third one is climate change and environmental health. And the fourth one is reaching the unreached. And in this vision document, we indicated that the citizens do not die from cardiovascular disease, cancer, chronic respiratory disease, and diabetes before the 70 years of age. And we acknowledging the massive burden of NCD. The countries are requested WHO to help them to reorient and to strengthen the health system in order to provide NCD service that are focused on the people and also accompany them through their life course and in an integrated way, especially focused on strengthening the primary healthcare system. This will give countries, especially for low and low medium income countries and Pacific Island countries in the region, a fighting chance to achieve universal health coverage and sustainable development goal and to reduce the risk of citizens dying from NCD. Next slide, please. So as I already mentioned, there are 4 thematic priorities that member states already endorsed in the Western Pacific region to achieve. And in each, we could see that the NCD and aging is one among 4 thematic priorities, among the health security, climate change, and reaching the unreached. Next slide, please. So WHO very much, pay attention to the partnership because we consider the partnership are essential for driving action and evaluating the progress, especially the partnership across sectors beyond the health sector and partnering with the civil society playing a critical role in delivering the action. And we also consider the public-private partnership is an opportunity to facilitate and mobilize more efforts and resources for NCD prevention and control. And like a digital health solution could be one of the areas that public-private partnership could be play the role. So as you may know that COVID-19 and NCD together could be viewed as a syndemic. These 2 epidemics, one acute and the other is chronic, accelerated socio-economic inequality, and the resulting in social damage is worse than the sum of both. However, there is no clear timeline when the syndemic will end, and this uncertainty is the impetus for all of us to quickly consolidate our efforts. And we really look forward to the discussion today to exchange ideas and generate commitment how we look forward. And as the Professor Richard Hobbs already mentioned, and also in the keynote speech of Professor Sood, we see that digital technology is an essential and the central part for both NCD and COVID-19 response. We see that many countries are utilizing the digital technology to scale up the detection, prevention, screening, and self-care for NCD. And similar to that, the COVID-19 response efforts also has been using a number of digital solutions like for contact tracing, for patient follow-up, and for surveillance. So we think that it is a great opportunity for us to discuss. And thank you very much, Madam Chair, and everyone for your listening. Over to you, Madam Chair.
Dr. Tran, thank you so much. And I particularly like your focus on the 4 priorities for the region. Very clear, thank you. We're now going to move on. Actually, we're going to move to Kuala Lumpur, where we have Dr. Faisal Idzwan Mustafa, who is a doctor and deputy director of the NCD section at Malaysia's Ministry of Health. And at the Malaysian Ministry of Health, his main roles include policy and program development and strategic implementation of interventions for the prevention and control of NCDs. In addition, Dr. Faisal is interested in using technology to change behavior and to reduce the exposure to NCD risk factors, which has been a theme so far. Dr. Faisal, over to you.
Thank you very much, Baroness, for the kind introduction. Good morning, good afternoon, everybody. Could I have my slides, please? Right. So I'm just going to frame my discussion based on this framework of the continuum of care for NCDs. starting from the prevention, looking at early detection, the diagnosis, management, rehabilitation, and palliative care. I think that will be the full continuum. And any discussions with regards to use of digital health, I think we need to be cognizant of the fact that these are context specific with different countries, hinge on their healthcare system, hinge on their population behavior. However, I like to point out that a lot of discussions on digital health has always been on the center bit, on the management bit. I think let's not forget the full continuum of care. And over the last few months, since I've been doing this kind of webinars, I've realized that people hardly touch about the supporting activities with regards to the delivery of care. You know, how about your training, your continuous medical education, which is usually ongoing. A lot of things are being taught on the job for a lot of healthcare providers, especially non-physician healthcare providers. Monitoring and evaluation. A lot of countries and low middle income countries, their monitoring are basically still very much paper-based. They don't have EMRs. And the other component is the research. Which is important when it comes to evaluating the activities or the programs that is being implemented. And so this is what I would say the full range of activities. And I will not delve into too much detail about the disruption due to COVID-19 and the restriction movements due to COVID-19 that has affected these different components. Some have been touched upon by the earlier speakers, and some will be touched in a bit more detail in some of the speakers after me. But I just realized over the last few days thinking about this issue, the technology that has been utilized is there already. You're talking about apps, you're talking about teleconsultation, you're talking about delivering medications to patients directly. It's been there, but or even this meeting that we have, you know, this virtual platform is not new, but circumstances have made it, has accelerated the use. So I'll just take one example. One of, I would say, the more popular examples being shared by Malaysia is the My Sejahtera app, a smartphone app that's been used for various activities, contact tracing, hotspot tracker, health risk assessment at home, linked to quarantine. So right now, out of the 31 million population in Malaysia, the registered users of My Sejahtera is 20 million. That's basically almost all the adult population is using the app. So it's just that circumstances have made us, it's a necessity now for us to move around, to use the app for ease of checking in. So that's just one example of, you know, it is an app. There's plenty of apps out there, but just circumstances have made it change. Virtual training, such as using Zoom or any other platforms, that's becoming a norm now. For meetings, I've been involved with at least 2 initiatives where I would say it's 100% virtual. It would have been unthinkable pre-COVID. So I think it was the circumstances. That's one point that I like to raise that has accelerated the use. However, I think it is important for us to understand the behaviors of the users, both the healthcare providers, if you're talking about digital health solution, and the users, either the patients or the at-risk population or apparently healthy population. Because it is important for us to understand their behaviors before COVID-19 and due to COVID-19. Because technology, digital health is not just about the technology. Just because something have bells and whistles, look pretty, that people will use it. I think it's really down to understanding the behavior of the users and looking at the circumstances as well. So for example, when it comes to teleconsultation, the current regulatory environment in Malaysia pre-COVID didn't really support in that direction, but during the COVID time right now, the Malaysian Medical Council came out with an interim guideline to enable the use of teleconsultation. So that's the regulatory environment, the environment around COVID-19, and understanding the behavior of your population right now and how we can learn from that and how we can maintain that as we know more about COVID-19 and as we learn more about COVID-19. All right, next slide, please. The other point I like to raise, again, you would have, I think most of us would have seen this slide, is the idea about the collateral damage due to COVID-19, particularly on NCDs, and taking the bigger view of NCDs to include mental health. When it comes to monitoring, so I'm just going to talk about monitoring right now, a lot of countries, LMICs, will be ill-equipped to be able to track this in a timely manner. The current monitoring framework for NCDs do not cater for this collateral damage. So that's one aspect that we need to think about. And the other aspect is that how do you manage these conditions that is going to manifest itself? Digital health is a tool. There was a comment in the Q&A box. I agree with you, it is a tool, but we need to really understand the behavior of the population to optimize the tool, because the danger for me is the disparity between the haves and the haves not. We already know NCDs disproportionately affect the lower socioeconomic class, and we know already digital literacy and digital and health literacy is lower in these more vulnerable populations. So we need to ensure that whatever digital health solutions that we are developing right now or we are promoting do include those vulnerable populations. I'll stop there first. Baroness, I'll pass back the mic to you. Thank you very much.
Thank you so much. And thank you for your excellent slides. I think we'll move on rapidly, if we may, perhaps so that we get some time for some questions at the end. And I'd first like to go to Dr. Harpreet Sood, who's a board member of Digital Health London. He's got experience in both international and national health policy, with a particular focus on innovation, on emerging technologies around digital health. So how can technology help us, Dr. Sood? We're looking forward to the solution.
Thank you, Baroness Rolf, and wonderful to be here on the panel. So look, I don't have the magic answer for you this morning or this afternoon, but we'll certainly have a discussion on how we can move towards the intended goal. So and thank you for the introduction. So I'm a GP or primary care physician in the UK, based in inner city London, and also on the board of Health Education England, what is responsible for the workforce training and development in the NHS in England. So I'm just going to give a brief overview of some of the things that I'm seeing as a primary care physician, which I think is relevant, because that clinical viewpoint in this perspective is really helpful to understand. So I won't go into the detail like my colleagues have done on some of the explosion that we've seen with the use of digital and digital health. You know, we've seen a tremendous amount of investment that's gone into it. If you look at US companies, we've had nearly $5.4 billion gone into digital health solutions. So it's clearly a market that's of interest, and we've seen groundbreaking IPOs and merger and acquisitions. So lots of activity happening in the infrastructure space. I think from a care provision perspective, it's of interest. Now, remote consultations have certainly sprung up. And if I look at pre-COVID around March time, I was probably doing about 3 to 4 telephone calls a day in my clinic. And that rapidly shifted to about 25 to 30 calls within a matter of weeks once COVID was alive and it became a pandemic. And so that was nearly over 90–95% of my consultations being done remotely. But videos were very few. And I think that's a really important distinction to make, is that a lot of people assume that because we have the technology, we're all using it. Actually, videos were very, very limited. And the majority of it was done via text or telephone. And again, generally in the NHS, the picture was very similar, where we saw from around 15–20% of consultations being done remotely to over 50 to 60%. So not all the way to 90, but a good significant proportion. And the vast majority, actually, we were seeing consultations being done in the 18 to 49-year-olds. So that's an important distinction again, because if we look at some of the presentations we've seen on the NCDs today, often NCDs are in a much older age group. And so we need to take that in mind when we're thinking about technology. And on that basis, we're also seeing a tremendous use of more remote monitoring and diagnostics. So a lot more pulse oximeters being delivered to people's home, trials of high blood pressure, hypertension, blood pressure machines, but also thinking about how do we actually manage conditions like COPD, but also diabetes. And diabetes, obviously, as we know, has made tremendous progress in terms of remote monitoring with various solutions out in the market at the moment. And then the final point I just wanted to raise in terms of the good progress that we've seen is actually in the research and clinical trial space. So in the UK, for example, digital has really allowed us to progress with the recovery trial. We've seen the speed at which we've had a national trial set up, where the recruitment and getting people consented and leveraging on the data systems that we have currently in the NHS. And I think that has been a fantastic response to it, and we've seen some excellent results that have come out of the clinical trial. And we need to think about, even from a research and secondary uses of data perspective, how do we ensure we can keep some of the good things out of that, because research will ultimately lead to better outcomes as we start developing the evidence. Now, I think, Dr. Faisal touched upon this, and I think what we've seen is that there's been a greater acceptance of the use of technology, not only amongst the patients, but in particular amongst clinicians. And I think that's really a game-changing mentality. So if I look at some of the more senior experienced clinicians in my field, many of them would have felt that digital actually is quite arduous, it's quite time-consuming, and we don't want to use it. But the speed and the ease of how they've been able to use it has actually been that it's made them think that actually this is now good and it can work, but we need to think about it a lot more. And also the trust aspect. So there's a lot of people who are willing to trust the use of technology in order to provide care. However, with that all in mind, I think there's 5 key things for us to really think about deeply in terms of some of the challenges ahead. And this, I think, will really could destall some of the progress that we're making. First, it's a regulation side of things. So how do we ensure we keep high benchmark? How do we not cut corners? Because we're starting to see, some companies cutting corners, some solutions not going out there and doing what's necessary in order to get contracts. And I think that could be a real detriment to the progress that we want to see in this. Linked to that is the idea of how do we maintain quality and safety? Again, things like cybersecurity, things, moments like, maintaining a high level of trust and quality and safety, and how we provide these solutions is really important. The third, and I think the most important aspect of it, is the evidence and evaluation. Now, we've all jumped into this use of digital and technology very quickly out of necessity more often. And what we've done is gone from one extreme to the other and missed a tremendous amount of learning in between. And so, where I thought, for example, in my clinic that dermatology would be a great speciality to use remote consultations, it became very quickly that actually dermatology skin cases weren't very useful done remotely because of the quality of the patient's cameras or the light or certain aspects of that. So having the clear evidence and clearly evaluating the use cases, thinking about pathway redesign, thinking about how we're doing things differently, that will really be the game changer, because essentially the technology then just becomes a sticky plaster that we put on things that may have not already been working because we think there's some excitement there, but ultimately it doesn't change the fundamentals. Fourthly, I think it's really important that we don't widen the inequality gap, which a lot of this is now. And a recent example I've shared is that, a few of my patients, for example, many of them are quite reluctant to often use digital and their smartphones to consult with their doctors because they don't want to use up their data to consult because of the limited amount they have. They want to use it to call their families up or friends. And I think that's really important, that we can't just assume that as we use these technologies that it's going to be for everyone. And we have to think about that. It's accessible, but it's also the aspects of equity there so that we don't widen inequalities. And then finally, with all of this, and I think this is the issue for not only more well-resourced health systems as opposed to less well-resourced health systems, is the idea of what are some of the economic models for this to be sustained. At this point, in particularly in the Western nations, we have seen that we have a lot more investment and legacy with the infrastructure that we've invested in. And so the economic models there could be different to the ones that we may have in less well-resourced nations. And I think that provides an opportunity in that if we were to design a health system today, would we rely on as much bricks and mortar versus more online and less offline? And I think that balance is going to be really interesting to see how it plays out in many of the less well-resourced nations, because if we can develop health systems with technology as a key feature and enabling it, we may see a much more interesting hub and spoke model that will allow us to actually invest less in physical locations, but more in remote or online solutions. And I think developing those clear economic models will be really important, which I think we can all learn from. So that's kind of a very brief overview from where I sit. So I think it's here to stay, but I certainly think there will be a recalibration in terms of how much of technology we actually use. But one thing is for sure, that there is a tremendous amount of prospect for it, but it has to come with the right evidence and evaluation for us to make the impact to those that need it most, especially those with NCDs. Thank you.
Harpreet, thank you very much indeed. Very, very stimulating and challenging. Our final speaker this morning is Miss Jo Feng, who's the Senior Vice President for the Asia area for AstraZeneca, for whom I'd like to thank, as it were, being co-organizers of this seminar. She's in Shanghai, and she's got nearly 22 years of experience in the pharmaceutical industry. She started life as a neurological physician in Shanghai, and is responsible for the growth and performance of businesses for AstraZeneca right across the Asia area. So, you know, everywhere from South Korea to Bangladesh. I won't read out the list. You know, AstraZeneca, of course, is particularly prominently in the news for the vaccine collaboration with Oxford, which we've heard about. But Jo's main focus is on chronic diseases and working to overcome the difficulties that patients have faced during the pandemic, which I think has been a theme that's come through today, the impact on NCD of the pandemic and how we deal with that. And I think plan for a future where that doesn't happen again. Jo, over to you, please. Ms. Jo Feng.
Thanks, Baroness. Thanks for inviting me to represent, you know, how AstraZeneca, what we have done to anti the COVID-19. But before I start, you know, I want to say a big thank you for Vietnam, Malaysia, Thailand, and also as other government in the Southeast Asia. And you have done a tremendous job to fight COVID-19 and to protect our patients. And no one has this kind of, no one had this kind of experience before. But I think together we have made a tremendous efforts to help the patients. And when the pandemic started early of this year, the key focus for AstraZeneca is to make sure the safety and the well-being of our patient. So our first job is to make sure the supply of our medicine to the Southeast Asia, and to make sure patient can get the treatment and the medicine. Second of all, we have donated more than 500,000 of the mask and also the other PPE to the HCP and the nurses in the Southeast. And also we have held the webinar to collect more than almost like 8,000 HCP to join the webcast meeting to discuss how to anti the COVID-19 patients, especially with the NCD patients. And on top of these three key initiatives, we have also worked a lot with the digital-driven healthcare initiatives, which I will present you in the next slide. Next slide. Please go, yeah. So when we look at all the patient flow, we understand that during the COVID-19, actually the NCD patients, the number dropped a lot in all the manners. For example, the chronic disease patient, the OPD number dropped to 50 to 80% in most of the Asia area country. So the key challenge focuses on the 4 areas. For example, patients don't understand the linkage between the COVID and also their own disease. Taking Malaysia as the sample, Malaysia has a relatively higher prevalence of the diabetes in the world. And it's no surprise to get additional pounds when you lock down at home and everybody become the very good chef. So in Malaysia, AstraZeneca has worked very closely with MOH to provide the digital diabetes education to the patients. Actually, this is the idea from Dr. Faisal, who is also in the panel today. So thank you very much for your idea. And also we see all the other markets like the Philippines, they supported the cancer hotline. And also in Indonesia, we supported the digital disease education and treatment as a partnership as well. When we see the big drop of the NCD, including heart disease or the cancer in all the hospital, we have also worked very hard to open the channel to connect the HCP with their patients. So for example, AstraZeneca Philippines worked with the biggest distributor to set up e-app to have the end-to-end support to the patients, from the e-consultation to e-prescription, and deliver the medicine to patient home. And in Vietnam and also in Singapore, we have supported the National Cancer Center on the telehealth system. And also in other countries like Thailand, we also start to explore whether we can do the liquid biopsy to have the early diagnosis of the cancer patient as well. So for the patient that disappear, this is a key challenge for the early screening or early diagnosis, especially during the COVID period. So in Vietnam, AstraZeneca has worked together with the most famous Baham Diabetes Hospital in Hanoi to have the telehealth program for the chronic disease NCD patients. And for Singapore, we just start the collaboration with the Singapore local startup company called Echo AI, which can use the echocardiography to have the early screening machine learning on the heart failure diagnosis. And this program has escalated to the global collaboration between AstraZeneca and also the Echo AI, the startup company. And the last but not the least, I mean, the very difficult for the early diagnosis for some of the NCD disease. For example, TB versus the lung cancer. So we just started to work with a startup company to use the AI technology to use the X-ray instead of the CT, because the low dose CT is not available everywhere in some of the country. So we use the X-ray to differentiate the early stage of the lung cancer, nodal, or the TB. So I have to say these all initiatives that they are still quite new in the early phase, but we believe that with the continuous efforts, collaboration between the government, doctor, startup partnership company, and AstraZeneca, we will be able to help more patients in Southeast Asia. Finally, I'm very inspired by the previous slides showed by Dr. Truong, saying that in West Pacific countries, no patient will die before 70 years old because of the heart disease, cancer, respiratory disease, and diabetes. So together, we hope we can also help to this goal. So thanks very much. Back to you, Baroness.
Thank you so much, and thank you to all the panel. I'm now going to move on to questions, and I'd ask you to put questions onto the Q&A. And I'm going to start with the first question, which is for the Deputy Minister. And I was so glad, Deputy Minister, to see Gareth Ward, our UK Ambassador to Vietnam, sitting beside you. So welcome, Gareth. It's great to see you. But the question is from Simon Lovegrove, and it's a very wide one. It is on the importance of city development with regard to parks for exercise, minimizing pollution. So how important are smart cities and urban planning for the healthcare of residents in Vietnam and in ASEAN countries? Deputy Minister. Unmute.
Be here, but now he have some mission and out of this room.
Who would like to take the question?
From Baroness. It's a very, very big question for me and for us, because as you know, the trend in the world that they are trying to build a smart city. In Vietnam now, Ho Chi Minh City, we have a plan to build up a smart city in Ho Chi Minh City. And a comprehensive solution should be applied for all of domain, all of the region, and all of the citizens in the city. So I think that not only for healthcare system in the smart city, but also for the other facilities like electric, like camera, like traffic control, it also involve together to how to integrate it together in order to build a smart city. And for the healthcare system, I think that is a big challenge for not only in Vietnam, but in many countries, that how to make the assessment of the patient as how to the patient can access to the healthcare services as soon as possible, as well as possible, is the one of the top topic that we should trying to do that. And the digital health in the smart city is very important. So by this system, the patient, the people and the patient can be accessed easily, and also can be managed by telehealth as possible, as soon as possible. And also, I think that is one of the big role of the healthcare system in the smart city. Beside the other reason, beside the other domain, I just some comment for that. Thank you.
Thank you very much indeed. And I think, you know, open spaces are important, but people need to have, you know, healthy buildings to live in, whether it's at home or at work. I'd like to move on, if I may, and take a question from Matt Kavanagh, who's also a board member of UK-ASEAN. He's at the Prudential, which is the leading life and health insurer across ASEAN. He says, our smartphone-based digital health initiative, Pulse, is a good example of how new initiatives have been accelerated across the majority of ASEAN countries. So in Vietnam, for example, there's 1 million downloads in 3 months. And one of the speakers mentioned the sheer scale, I think it was in Malaysia, of the use of phones. The basic version is free to use. And we agree with Dr. Faisal and others that we need to ensure this is available to everyone. So the question is, to the panel, how can public and private sectors work together to make the most of these new initiatives? Are they confident that the support which regulators have given the initiatives during COVID will continue? And can AI help? Shall we start with you, Dr. Faisal?
Thank you very much, Baroness. That's an easy question to answer. So firstly, with regards to public-private partnership or PPP, I think it's easier said than done. In a lot of countries, we don't really have a structured framework. I use the word, a lot of times it is a black box. How come you can work with company A and then how come you cannot work with company B? I think with the lack of a framework of engagement, which has transparency and accountability, it's very difficult to do this on both parts, both the government and also the private sector. So what I've been doing really at the moment is in a way champion-driven. It's unfortunate when it comes to champion-driven, it's very difficult to sustain. You know what I mean, right? When a person is there, it goes on. When the person moves to other position, it dies away a natural death. So I think we need governments, not just which governments need to have a clear framework engaging the private sector, not just saying, oh, we encourage PPP, because I think a lot of governments encourage PPP, public-private partnership. So going on to the next question in terms of making it accessible, I just would like to relate, it is about really understanding the people who would benefit the most. So one of the things that we did over the COVID-19 period was to run a survey because we were curious if we want to run a digital health initiative for our diabetes patient, and this is diabetes patients specifically, coming to our MOH health clinics, and 75% of patients with diabetes come to MOH health clinics. So we asked them in terms of their utilization and source of information coming from social media and digital health, not traditional media. We did ask about traditional media, but what I'm going to share with you in terms of the digital health, only 2%, 2, not 12, 2% would use an app. And this is not surprising really, because their average age is 60. They are more of the lower socioeconomic class. And like I said, it's just about understanding the person. So I'm not saying don't push for apps in this kind of situation, but you need to address that as an important component, not just develop the technology, but understanding and how you can motivate or educate or whatever to raise that. So again, I just like to reiterate my earlier point. It's not just about the tool, about the toy. I use the word toy sometimes. It can be all shiny and people expect play with shiny toys, but people don't. So it's understanding about the population who are at most risk and who would benefit the most from technology. And I would agree with what Harpreet said earlier. It was the phone calls rather than the video calls, which work well. And right now, one of the things that we are working on is looking at SMS based technology, which we think would benefit, but we will try it out. We are in the process of developing and trying it out, and hopefully we can report back. So I'll stop there first, Baroness. Thank you.
Right. Yeah, I think you called it pathway redesign was important. I think I was listening to what you said. Dr. Sood said that earlier, which I think comes in here. Actually, I should perhaps bring in Dr. Tran on that question, because partnership was one of the things that she emphasized in her talk. Did you want to comment on Matt Kavanagh's comments, Dr. Tran?
Thank you very much, Madam Chair. As I mentioned earlier, the partnership play a critical role in addressing NCD because, as you may know, that all the risk factor contributing to NCD are beyond the health sector responsibility. So it would be great to have multi-sectoral collaboration for NCD prevention and control. And I see from the chat box, some participants would like to emphasize on the prevention side for NCD, which is very relevant, and it is a very cost-effective way for prevention of NCD. Another aspect, which is a partnership between a public and private partnership, and I think just putting more focus on the digital health, that with the investment of the industry for digital health, that will have provide a great opportunity for both COVID-19 response as well as maintaining the health services during the pandemic. And it has been shown in the presentation by Ms. Jo Fang that some countries in the region already saw great potential, and also action had already taken to show that the use of digital health for management of NCD shown to be very effective. And we think that, of course, we need to have a partnership with the private sector to strengthen this part of collaboration. And then we will have a concerted efforts and resources to be up for this effort. And we think that for COVID-19 pandemic, it is great challenge for all of us, but it is also an opportunity to find a new way, to find the innovative way to address health issue. And just for your information, last week, WHO for the Western Pacific region has organized the Innovation Forum. We have a participation from many member states, and it shows that there is a very great momentum for moving forward in utilizing the innovation for healthcare. Thank you very much.
Thank you very much. I'd like to bring Dr. Hobbs, Professor Hobbs in, if I might.
Yeah, thank you very much. I mean, I think these are important questions. I mean, if you look at most aspects of our lives in many countries now, the impact of the digital technologies is remarkable. I think if we were looking for a hotel or trying to find our way home or wanting to do a bank transaction over the last 10 to 15 years, these have been entirely dependent on digital solutions. And I think what we want is a bigger debate around the role of digital solutions in healthcare that accords with what we're prepared to share for sort of normal life gain. what information do we need to keep protected and will only be available to trusted providers, and what we are prepared to share with the population, which gives very little information away. So, for example, the test and trace apps, the ones that have been using local networks that aren't using central repositories of data, have had huge uptake by populations who accept that they're giving a little bit of information away, but they gain a lot. And that dynamic needs to be debated more with the population. And I think it'll be that prevents concerns that stop, that get regulators stopping innovation in this space. I think it is going to be quite difficult determining who pays for this. That was one of the other questions, who should pay for this. And I think inevitably it's going to be co-pay. We're going to have to think through who has commercial to gain from this and therefore should be making an investment. I think if health systems are going to adopt digital solutions, they need a better evidence base. So we need to get better at evaluative science around digital health. And coming back to this point that's already been made, we do need to be clear about where solutions are in clinical pathways, but those clinical pathways are going to change. We are going to end up with a period of more targeted healthcare. We currently largely rely on average effects and therefore give treatments to large populations of people for an average response. And we clearly want to be focusing on people who have most to gain, particularly as biologics and things will get more expensive. So we need to actually redesign the whole economy around healthcare. And I think investment in digital health will help tease out these issues.
Yeah, a very, very strong point. Thank you so much. I'm on to the last question now, and I'm going to ask the Harpreet, Sood and Joe Feng to answer that. And then I'm afraid we'll have to wind up because I have to, I promise a drop dead 10 o'clock to our partners and customers. It's from Deepak Arora. And the question is, while we have seen a big leap at digital health during COVID-19, what's your view on what percentage of the transformation will stay and strengthen ex-telemedicine once things get back to normal? You know, obviously we're concerned to have long-lasting positive change, but what will stay? So just perhaps a quick answer from Mr. Sood, Dr. Sood, and from Joe Feng.
Thanks, Deepak, for that question. So look, I'm going to be honest here. You know, when we say transformation, we need to be clear on what we mean by that. I mean, frankly, from where I sit, you know, telemedicine isn't transformation. You know, it's just another medium that's allowing us to communicate with our patients. I think we start seeing real transformation when we really deeply think about pathway redesign. We think about community diagnostics. We think about how we bring care close to people's homes. How we think about you know how we do things much differently than we have been doing, and we've still got a long way to go on that front, including, like we've discussed in this panel today, generating that evidence and evaluation that allow a lot of this to stick. At this point, we're still in the experimental phase. Yes, we're trying out a lot of these technologies. We're trying out various aspects of it. We're trying out things like videos, but we still don't know who it works for, how it works, and how effective it will be. And until we get a much clearer answer to that, I don't think we're going to see a tremendous amount of transformation. In terms of the usage of remote consultations, I think we'll see a recalibration. So we'll end up probably seeing around half of our consults being done remotely. And I think that's the precedent from policymakers have given in the NHS, but that might differ depending on what part of the world you're in and how much accessibility you have to a data infrastructure, Wi-Fi infrastructure, plus smartphone technology. And I think that's, we have to wait and see how that plays out. But make sure we invest in evidence and evaluation before we start thinking about the transformation piece.
I totally agree with I totally agree with Dr. Sood. Sorry, Baroness.
Yeah, come in, yeah.
Okay, I totally agree with Dr. Sood, your view. I feel like, you know, when people have the choice of the face-to-face, they immediately switch back to the traditional way, which is a face-to-face. However, remember our generation, with all the e-commerce, with all the Amazon, people, they like to shop, you know, from the website. Then I believe that, you know, in future, when this generation getting old and get all the heart disease or some other disease, probably it's very likable for this kind of telemedicine in future. But however, how to do that, especially in the next 5 to 10 years, I think this is a long journey. I totally agree with Dr. Sood. We need to invest, we need to explore, but still, I mean, face-to-face probably will replace quite quickly when everything back to normal.
Well, thank you so much. And I think we'll actually have to have another seminar to talk about the future and the longer term, and perhaps ask some of you back. So, I mean, I think it remains for me, I won't try to sum up because I probably haven't got time, but I would like to make a particular big thanks to our partner, Dr. Khuong, but also to the Deputy Minister who's now left us, but I thought gave us a great introduction to, you know, to how COVID has impacted the health sector, including, I suppose, this disturbing shift in making treatment of NCDs, you know, reduced for a period. But there has been an extraordinary shift into digital. I thought his example, actually, of the villages with the healthcare system and contact points was something that I will certainly take away. Thank you all for an amazing panel. Thank you, Professor Hobbs, and I hope your slides will be made available. Thank you, Dr. Tran. Your 4 priorities are now engraved in ASEAN UK-ABC, Dr. Faisal, Dr. Harpreet, and Joe Fang, and we look forward to working with you all in partnership, pushing forward and making sure that the good things that happen digitally from COVID continue, and that we have, in Dr. Sood's words, pathway redesign. Thank you also to my own team and to Jasper Mines of AstraZeneca for setting up this seminar. I know how difficult it's been, but it's been absolutely worth it. So thank you very much. Have a good evening, have a good morning in London, and goodbye.
Thank you.
Thank you very much, Madam Chair.
Thank you all. Goodbye.
Thank you. Have a good day. Bye-bye.
Thank you, everyone.
Thank you. How are we for time? 1 minute over. That's good. Right.
One of your English chaps